Good afternoon, everyone, and welcome to our first medical grand rounds of the year. We appreciate you joining us, and I wish everyone here a best wishes for the new year. I'd like to just have a little reminder to please enter your questions in the chat at the end of the presentation. As well, I will ask you to please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you are here today. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous people. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Our first speaker of the year comes to us courtesy of the Division of Hematology, and we have here Dr. Chantal Séguin, the Chief of the Division of Hematology, who will present our speaker. Chantal, the floor is yours.
Thank you, Dr. Gianetti. It is a real pleasure and privilege to present Dr. Jean Saint-Louis this early afternoon today as the first of our medical grand rounds of this year. Dr. Saint-Louis has graduated from McGill. He has obtained his MD degree initially, I would say many years ago, and then continued for 3 years for a tronc commun in internal medicine for the first 3 years. And he then moved to the University of Montreal to complete a training in hematology. At that time, I had the pleasure to have Dr. Saint-Louis as a teacher, and I was a resident at that time on the University of Montreal side, and I remember him as an extremely dedicated physician. These are very good memories for me today to have Dr. Saint-Louis present to us. After his training in hematology at the University of Montreal, he then moved to New York to do a fellowship in oncology and hemostasis. He was then a fellow at the Memorial Sloan Kettering and then also at the New York Hospital, which is affiliated to Cornell University. Since then, Dr. Saint-Louis has been very active in the field of hemophilia. He's currently a co-director of the Hemophilia Treatment Center at the CHU Sainte-Justine and the Quebec Reference Center for Inhibitors. He's a member of the Hematology-Oncology Service at the Maisonneuve-Rosemont Hospital in Montreal, and he is also an associate professor in the Department of Medicine, University of Montreal. His research focus has been on hemophilia and coagulation inhibitors. Today, he's presenting on the revolutionary new treatments in hemophilia and what clinicians should know. And it's a great honor to have him present to our rounds today. And again, thank you so much for being with us, Dr. Saint-Louis.
Thank you very much, Dr. Séguin, and good afternoon to all of you and best wishes to all of you for 2024. Dr. Séguin didn't want to mention it, so you wouldn't be able to calculate my age, but I was at homecoming at McGill for our 40th graduation anniversary this past fall. So I was the class of '83, and it's nice to have been invited today. Thank you very much. This slide lists my potential conflict of interest, but I really have no specific disclosure in relation to this very broad talk today that I hope will be of interest to all of you. Why this talk is relevant, although hemophilia is rare, patients do show up in emergency rooms and surgical suites of the McGill Hospital network and are seen sometimes preoperatively by internists and anesthetists. So I think it's good to, every 10 years, have a little update on hemophilia for people in internal medicine, and there's been exciting new approaches to hemophilia care after perhaps 30 years of a fairly standard classical approach with factor replacement therapy. There's been very innovative treatments that have started to be offered to patients. They show the beautiful, the power of medical innovation, and they also remind us of the delicate balance of coagulation and thrombosis, which is something I love to teach about. Not many of you love to be reminded of coagulation, but we'll hopefully do that in an interesting way today. So my objectives are there. We will review the basics of hemophilia and its classic treatment. Then we'll try to understand some of the biological mechanism by which non-coagulation factor-based therapy can ameliorate bleeding symptoms in hemophilia, and recognize how these novel treatments alter the clinical and laboratory presentations of these patients in routine and emergency care. So this is a very real situation that could occur to you in the ER of your hospital tomorrow evening. 55-year-old diabetic patients with severe hemophilia A could present with hematemesis, melena, and retrosternal chest pain. This older man or middle-aged hemophilia man has chronic hemophilic arthropathy and has used some celecoxib on and off over the years for his joint pain and stiffness. When he arrives, his hemoglobin is 72, his MCV is normal, his troponin is 96, and the EKG shows no ST elevation. Curiously, his APTT is very short, 22 seconds for a normal range of 30 to 42 seconds, and you obtain the factor VIII plasma level at 400%. You learn that the patient is not receiving factor VIII concentrate, as you would expect, but he's on prophylaxis with an antibody, emicizumab. So what's going on? This is why we're having the lecture. So hemophilia is a disorder of blood coagulation due to hereditary coagulation factor deficiency. Blood coagulation comes about when a large number of plasma and vascular protein interact in a complex way, and that's your typical, very difficult to memorize coagulation cascade. I much prefer to show this one when I teach. So when there's a hole in a vessel wall, you need a plug, and the plug is usually made of platelets and fibrin. Platelets are the bricks and fibrin is the mortar. And in order for the mortar to gel or to be able to hold the bricks together, fibrinogen needs to polymerize and become a network, a meshwork that will hold the platelets together. And in order to do that, you need these coagulation factors, which are plasma protein that interact with one another. Obviously, it's a lot more complex than that very cartoon that I showed. There are natural brakes or regulatory proteins that are involved as well, and you'll see that those are now the target of therapeutic interventions in hemophilia, in particular the tissue pathway inhibitor protein and the antithrombin protein. There are also modulatory influences and interactions such as the blood flow forces, fibrinolysis, cellular and inflammatory proteins, and interactions that do influence coagulation. So it is generally a complex system, coagulation and thrombosis, as you know. But for our purpose today, we will focus on two coagulation factors, factor VIII and factor IX, that play a pivotal role in allowing the formation of fibrin because they don't initiate in and of themselves blood coagulation or plasma coagulation, but they play a critical role in the amplification of the coagulation cascade. So typically a hereditary deficiency of factor VIII will be called hemophilia A, and hereditary deficiency of factor IX will be called hemophilia B or Christmas disease. Now, coagulation factors are present in plasma at very low concentrations compared to other plasma proteins. So we all know albumin is about 40 grams per liter in a healthy individuals. Our immunoglobulins are about 20 grams per liter. Our transferrin is 2 grams per liter. The only coagulation factor which is very abundant in plasma is fibrinogen, which is at about 3 grams per liter or 3,000 micrograms per milliliter. If you compare this to the left, to the concentration of the other coagulation factors, you'll see that they're 2, 3, or sometimes 4 order of magnitudes less abundant if you consider their mass or their molar concentration. However, coagulation factors are not usually reported on the basis of their mass or molar concentrations, but they're reported as units, and you need to think about them as a unit of factor. So what's a unit of factor? It's defined from a pool of normal subjects, and if you take 1 milliliter of normal plasma, it contains 1 unit of all the coagulation factors, including factor 9 or factor 10. And you'll find normal individuals who have 0.5 units per ml of factor 8 or factor 9, and other individuals who have 1.5 units of factor 8 or factor 9 per ml. So the range of normal is 0.5 to 1.5, or we will often say 50 to 150%, considering that 100% of factor is 1 unit per ml. And if you look at the relationships between the clotting time, such as the APTT, and the factor 8 or factor 9 concentration. So if you look at this graph, as you're moving left on the x-axis, as your concentration or factor 8 or factor 9 goes below 50%, which is the lower limit of normal, you see that the APTT becomes progressively longer, but not in a linear relationship, but more in an algorithmic relationship. And you start to see with severe or hemophilia or moderate hemophilia, very long APTTs. So let's think about factor replacement therapy, which is how we treat hemophilia. So if you think as a normal adult, you have a blood volume of 5 liters and your hematocrit is 40%, which means you have 2 liters of red cells and 3 liters of plasma. So if you normally have 3 liters of plasma with 1 unit of factor per milliliter, and you're at 1% of your normal concentration, so you will have 30 units of factor 8 in your whole plasma volume instead of having 3,000. And it would make sense that if you want to correct the APTT and restore normal coagulation in the hemophilia patients, you would need to infuse either 3,000 units of plasma, which would be a lot of fresh frozen plasma. That would be equivalent of 12 units of fresh frozen plasma. So it would be much more practical to infuse the 3,000 units in the form of a lyophilized concentrate of factor 8 or factor 9. And these lyophilized concentrates have been used now for over 40 years. In the beginning, they were derived from blood donors, and they did transmit HIV and hepatitis C, as we all know, in the late 70s and early 80s. But this problem has been solved now for many years, but we were still treating until 3 or 4 years ago, very much the same way as we were in the 80s or 90s, treating hemophiliacs by replacing the factor with lyophilized concentrate. Now let's have a little word about the classification of hemophilia or the severity of hemophilia. So if you take the classic hemophilias, which are factor 8 or factor 9 deficiency, someone is said to be a severe hemophilia patient if his factor 8 or factor 9 is 0 or less than 1%, so very, very low concentration. These patients will experience, starting at the age of 6 months or 1 year, so very young boys, as soon as they start walking or putting weight on their joints as they're weight bearing, they start to develop spontaneous bleeding once or twice per month, mostly in the joints, sometimes also in the muscles. And they will present excessive bleeding with even minor trauma, such as bumping into a wall or the corner of a table. They will have a bruise that will be sometimes big. even at 2% to 5%, so even low, but low concentration, but present nevertheless at 2 to 5%, that's enough to change the phenotype quite a bit. So moderate hemophilia is when factor VIII or factor IX is between 2 and 5%. And then spontaneous bleeding is much less frequent, once or twice per year instead of once or twice per month. But there will be excessive bleeding with moderate trauma or major trauma, not so much with very mild trauma, minor trauma. And a mild hemophilia is defined as someone who has factor VIII or factor IX between 6 and 40%. I remind you that the lower range of normal is 50% or more. So these patients have no spontaneous bleeding, but they will present excessive bleeding after major trauma or surgery. So it would not be atypical to diagnose someone as having mild hemophilia in late adolescence or sometimes even in adulthood because of this milder phenotype. So it's only when there's trauma or surgery that they will come to attention if there's no family history. So hemophilia is the example of a classical X chromosome linked disorder. The genes for factor VIII or factor IX are on the X chromosome. So male only have one X chromosome. The Y chromosome doesn't have that gene. And so males who inherit defective X chromosome from their mother will be symptomatic. There's one case per 10,000 births. Hemophilia is present in all races. And hemophilia very much has persisted over the centuries, despite the fact that it used to be a fairly severe disorder, because 1/3 of all cases are new mutations or the beginning of a new dynasty, if you will, because factor VIII genes in particular is fairly unstable, and there's new mutations occurring in the ovum of young women who have no family history of hemophilia in their family. The ratio of hemophilia A to B is 5 to 1, so the factor VIII deficiency is a lot more common. And in Canada, you see that there's roughly 3,200 patients with hemophilia A, 680 with hemophilia B, and the breakdown between severe, moderate, and mild is explained there. So typically, as I said, for reasons that are maybe too long to explain, but the predominant site of bleeding in patients with hemophilia is the synovial membrane, which is very, very vascular, but has lower concentrations of some of the normal breaks for normal mechanism regulating coagulation. But again, it's not entirely clear because hemophilia patients very seldom bleed in their shoulders, but they'll bleed in their elbow, but not in their wrist. They will have very commonly bleeding in their knees and their ankle, but not so much in their hip. So there are still things that are not completely well understood with respect to the classical presentation, but these repeated hemarthrosis will lead to a very premature early onset of hemophilic arthropathy, which is a joint destruction without much inflammation, which will lead to deformity and to a person having severe mobility problem unless these bleeds are prevented. So the treatment of hemophilia is very, very simple. You just infuse the missing protein. So factor VIII and factor IX exist in their concentrate. And here you have a young person with hemophilia helped by a nurse who's learning to self-infuse intravenous factor VIII. So right away you see that an issue with treatment of hemophilia is the fact that factor VIII or factor IX are not absorbed orally, and they're not absorbed subcutaneously. They're large proteins, and they need to be infused intravenously, which is very difficult to do if you have a toddler or a young boy, and at age 8 or 9 or 10, they learn to self-infuse. At first, it's the nurse that does the infusion, then it's the mother, and then the boys start to self-infuse. So a key concept in hemophilia is the concept of prophylaxis. So It used to be that patients treated on demand, so they would treat only when bleeding occurred. And as we said, this was 2 or 3 times a month, but nothing was done to prevent the bleeding. But for now, over 20 years, the standard of care has been to do prophylaxis, which is to treat regularly 2 to 4 times per week. Again, it's intravenous to infuse factor VIII or factor IX to prevent bleeding. And the aim of prophylaxis is to maintain a plasma factor level, a trough level that is at least 3 to 5%. So never allowing factor VIII or factor IX levels to go below 3 to 5%. And in doing that, you're converting a severe case of hemophilia to a moderate or mild case with much less frequent bleeding. And another key concept is the annualized bleeding rate. So that's the number of bleeding episodes per year. But one big problem in wanting to do prophylaxis is that factor VIII or factor IX have relatively short half-life being infused or having to be after being infused. So the half-life of factor VIII is usually 8 to 12 hours, and the half-life of recombinant factor IX is roughly 18 hours. So to achieve prophylaxis, you need to do infusions several times per week. So if you compare an on-demand patient, he will infuse factor concentrate 30 times per year, every time he has a bleed. Sometimes he will have to infuse twice or 3 times in a row to treat a more severe bleed, compared to a patient on prophylaxis who typically has to infuse every other day or twice a week. So there can be as many as 150 infusions per year. But then their bleeding rates will be a lot lower. So prophylaxis is obviously a lot more costly and imposes a much heavier treatment burden, but it is the only way to reduce bleeding and pain, prevent hemophilic arthropathy, and prevent the rare but life-threatening bleeds such as intracranial bleeding, which does occur from time to time in severe hemophilia. So typically, here you have a 1 week represented. In the purple with a standard half-life concentrate, the patient will have to infuse 4 times a week, so every other day. For factor IX, or if you have an extended half-life concentrate, so some factor VIII or factor IX have been modified over the years, they've been pegylated to have a somewhat longer half-life where a treatment can be given twice a week. But this is still an intravenous treatment and still requires to self-inject over a lifetime. To be effective, to prevent the severe joint damage, prophylaxis has to be started very early, typically before the 2nd year of age. That's called primary prophylaxis, so before the second major joint bleed. And secondary prophylaxis is started usually before the age of 5, after 2 or 3 more significant joint bleeds. And again, this is a big treatment burden for patients, but it is effective, and it is the standard of care. But there's been a change of tack, a changement de cap. If you know what, if you've ever been sailing, when you tack, you turn the boat towards the wind, but by changing directions. So you change your directions by going into the wind. And the first true innovations that I'm discussing today with you is a subcutaneous treatment. And why I like to use the sailing pictures, I do like sailing, but there's something to be learned about the nature of factor VIII when you consider these 2 boats. So imagine that factor IXA and factor X are 2 sailboats on a windy body of water, an ocean. There's the wind, there is waves, and you need to transfer from one boat to the other a large suitcase. So you need some kind of interaction between the 2 boats. Obviously, if you're doing it at sea, it can be risky and complicated, and it's unlikely to work. But if you do it on the shore and you have a wharf there, you will be able to have this interaction in a much more efficient way. And if you will, factor VIII is one of those factors. It is not an enzyme, but it is more akin to a receptor or a a wharf, if you will, and the shore is actually the phospholipid layer of the platelets or the endothelial cells where the coagulation factor do assemble. So this new treatment called emicizumab is actually a bispecific monoclonal antibody that's been designed to mimic or imitate the action of factor VIII. So on this cartoon here, you see on the A panel what factor VIII does. Factor VIII is like a wharf, or it is attached to the plasma membrane of activated platelets when it is participating in a coagulation cascade, and it will assemble factor IXA to factor X to increase by several order of magnitude the efficiency of that enzymatic reaction, so that factor IXA will activate factor X. So this new treatment is actually it's not a coagulation factor, but it's a monoclonal antibody with each arm has been designed to have a separate target or epitope. So emicizumab mimics the action of factor VIII. It's a bispecific monoclonal antibody with one arm with affinity for factor IXA and the other for affinity for factor X. The big difference is that it doesn't bind to the phospholipid membrane of activated platelets where normally coagulation is activated. So it is present in very much higher concentration in the plasma than factor VIII is present, but at the same time is much less efficient than true factor VIII. You see here the KD of the affinity of emicizumab to factor IXA is in the micromolar range, whereas real factor VIII has an affinity in the nanomolar range for the KD of its interaction with factor IX and factor X. So apart from these differences, though, there are great advantages to emicizumab. In other words, because it is a monoclonal antibody, it can be given subcutaneously, and it has a very long half-life. So after you begin treatment, after the first 4 weeks of loading doses, the patient can be treated once a week or once every 2 weeks or even once a month, and it will they will be able to maintain a constant level of emicizumab in their plasma, and that level even at full dose, and even if you were to increase the dose at maximal sort of saturated dose, the activity is equivalent to the 15% of clotting activity of factor VIII. So you have steady levels compared to when you do a normal prophylaxis where you infused every other day, where you get peaks of 50 to 80% and trough of 0.0 to 5%, and where you may have more breakthrough bleed than actually with emicizumab. So this medication has been in use now for roughly 10 years. It was in clinical trials for 3 or 4 years. It was approved for the treatment of hemophilia in Canada 4 years ago for those with the most severe form who have inhibitors to factor VIII, so who are not able to be treated with factor VIII. And it's been used in all the other hemophilia patients with factor VIII deficiency in Canada for now 18 months. And there's been several publications. I'm not going to go over all the literature, all the pivotal trials to lead to its approval around the world, but just suffice to say that on emicizumab over up to 3, 4, 5 years of follow-up, patients have had annualized bleeding rate of less than 1 on emicizumab, and in comparative study, this was actually superior to standard prophylaxis. And even again here, when you look at the number of weeks over 2 or 3 years of follow-up, a very substantial number of patients had 0 bleed during the year. 82% experienced 0 bleed, which is again superior to what was generally seen with even good prophylaxis. So there's significant advantages of this medication over the traditional prophylaxis. It can be administered subcutaneously, which has made an enormous difference in the life of children and families. And even adults really appreciate the fact that they can treat a lot less often and don't need to access their veins. It gives an excellent protection against spontaneous bleeds. The patients are true mild, but they're not protected against bleeding if they have major surgery or major trauma, because 15% is not enough to protect you in case of a severe hemostatic challenge. The drug has very few adverse reactions, and it's been adopted now by over 50% of patients in Quebec and in Canada. But one issue with the drug is that it does substantially alter as an artifact your regular coagulation test. So typically a patient on imicizumab or Hemlibra will have an APTT that is 10 seconds shorter than the lower range of normal for your lab for the typical APTT. And if you were to try to measure factor VIII, it appears to be very elevated, but it's not the true factor VIII. It's again an artifact, whereas the true clotting activity is more around 15%. And in order to be able to assess what is the true factor VIII, in case you have to supplement with factor VIII, you need to do these coagulation tests by chromogenic method, which was until 2 or 3 years ago not really available very much in North America. And as of now, it's available in the hospital where there are hemophilia treatment centers, such as the MUHC or Sainte-Justine or Maisonneuve-Rosemont, but it would not be readily available in other hospitals. So if we go back to our case before, we remember this patient who had seemed to have a serious upper GI bleed with a low hemoglobin, and he's been receiving emicizumab, so that's why his APTT is short and his factor VIII appears to be very high. So this will be definitely complex management with endoscopic therapy, red blood cell transfusion, perhaps being monitored in the coronary care unit, but the patient will require infusion of regular factor VIII on top of his imicizumab to truly normalize his coagulation. So this drug, it is deceptive in a way. The patients do very well. If you do their normal coag test, they appear to be supranormal, but they can still very much bleed because their true activity of factor VIII is only equivalent of 15%. I'd like to move now to some other even more innovative directions that we've had in hemophilia care. And this is an area called rebalancing or non-factor therapy. So you could say imicizumab was a bispecific monoclonal antibody. So it's not really a coagulation factor, but it very much mimicked what factor VIII did. You notice that this treatment is not available for patients with severe deficiency of factor IX. So hemophilia B patients are not eligible for treatment with imicizumab. So what else is new? Well, again, if we go back to the coagulation cascade and its normal, its complex interactions, what if instead of replacing factor VIII or factor IX, we would remove the natural brakes to the coagulation cascade? So these normal regulatory mechanisms are antithrombin, which inactivates thrombin and factor Xa. Tissue factor pathway inhibitor is also a naturally occurring protein which inactivates the complex between factor 7A and factor 10 and tissue factor. And there's also the activated protein C system, which inactivates factor 5A and factor 8A. But two of these, in fact, have been the target of a therapeutic treatment for hemophilia. And the concept, let's see if I move my slide. So the concept is that if you have a deficiency of factor VIII or factor IX, you have a severe imbalance between your natural coagulants and your natural anticoagulants. And just the opposite, if you have a severe deficiency of antithrombin or protein C, and you have all your coagulation factor, you have a thrombophilia, you have a predisposition to thrombosis. But what if you were able to eliminate or block the activity of TFPI or antithrombin? Would that be able to compensate for the deficiency in factor VIII or factor IX, and in fact be an effective treatment for severe hemophilia? And so there's been two classes of medication that have been in use. One is called fitusiran, which is a small interfering RNA or silencing RNA, which is infused once a month or once every 2 months. It's a subcutaneous injection, and this RNA is made to bind with the mRNA of the antithrombin gene. So the antithrombin DNA is translated into the antithrombin RNA, and before it is translated into protein, if it binds to this silencing RNA, there will be no antithrombin synthesis. And so what you do when you use this medication is you induce a relatively severe antithrombin deficiency. If you've been doing thrombosis, you would know that when your antithrombin is at 40% or 50% of the normal concentration, patients are considered at fairly high risk of spontaneous thrombosis. Well, with this medication, you can in fact lower antithrombin by more than 75%. So I've had a patient who's been running with an antithrombin level of 10 or 15%. And you see here that within the clinical trial of this medication, there was a dose-related effect of antithrombin lowering on global coagulation. So you can't use the PT and PTT to assess the effect of this drug, but there's a test called the thrombin generation time, or peak, which is in this assay will give this kind of level in healthy volunteer. And the more you lowered antithrombin in using the plasma of hemophilia subjects receiving fitusiran, the more your coagulation potential of your plasma approach normal. So that medication is not yet approved in Canada or in the US, but it's been in clinical trial, and I've had patients on this medication who were otherwise not eligible for other treatment. Another drug, which has very recently been approved in Canada for a very specific subset of hemophilia patients with hemophilia B with inhibitor to factor IX. So this is a monoclonal antibody. It's this one here, concuzumab, which binds to this protein called tissue factor pathway inhibitor. What this does is that normally when tissue factor is expressed, it approximates factor 7A and factor 10 to activate factor 10. And this reaction normally is regulated and controlled by this TFPI, and this monoclonal antibody binds to TFPI and prevents it from inhibiting this reaction, then rebalances coagulation. So this drug also is available subcutaneously as an alternative to intravenous treatment, but this drug has to be given daily subcutaneously. But it is very helpful for patients with severe hemophilia B who are otherwise not eligible to treatment with factor IX. So rebalancing agents are effective subcutaneous prophylaxis in hemophilia B or other rare deficits, such as patients with inhibitors. They have been in limited use for now, mostly within clinical trials. Early clinical trial experience was difficult with these drugs. There were thrombotic complications which stopped their developments, and the clinical trials, the pivotal trials, were restarted after dose adjustments and adapted careful management in case of bleeding. So contrary to imicizumab, where it is very safe to give factor VIII to a patient who has imicizumab on board, if you do give a lot of factor VIII or factor IX to a patient who has a very low antithrombin level or an anti-TFPI inhibitor, you could see down now that you make them prothrombotic and not just rebalanced. So managing surgery or managing breakthrough bleedings in this patient is very more complex. A final innovation that I want to mention, and that's really at the forefront of science now, is gene therapy, which is now a reality in hemophilia. And I don't know if Dr. Warner is with us today, but she actually was in charge of the first case in Quebec of gene therapy in hemophilia B at the MUHC. I think the patient was treated about a year ago as part of a clinical trial. So what are the principles of gene therapy as far as hemophilia is concerned? Well, you have a monogenic disorder, which it lends itself well to gene therapy. So in hemophilia A or B, you have a factor 9 or factor 8 gene that is mutated and not able to produce enough protein. So you can use the gene you can obtain the gene by a recombinant method, package it into a viral capsid of an adeno-associated virus. You can have sufficient viral elements to allow translation of the factor 8 or factor 9 gene, but not viral replication. So this construct is not a live virus, and it doesn't have the ability to replicate. It can only insert itself in the nucleus of the hepatocytes, and then the machinery of the nucleus of the host cell of the hepatocytes, plus some of the elements that allow for the translation to begin. Allow the hepatic cells of the subject, of the recipient, to begin making clotting factor. So the transgene remains mainly in the episomal form. It means it's a sort of a circular DNA molecule that does not insert into the chromosome, therefore much less likely to disturb proto-oncogenes and cause other mutagenic events. And there's so far have not been secondary cancer related to gene therapy in hemophilia. However, because of the presence of this abnormal gene or compound in the cell, there can be an immune response that can be elicited. So there can be a hepatitis, and in which case there can be destruction of the host cells and expression may be lost. So gene therapy is very much now a reality in hemophilia. The FDA has approved two compounds, one to treat hemophilia A and one to treat hemophilia B. Now these have been approved for general use for about a year in the US. And in Canada, there's been two gene therapy treatments that have been approved. One very recently, 2 weeks ago, and one about 6 months ago. And both are approved for the treatment of hemophilia B. So what are some of the main issues with the gene therapy that one should know about? So there are issues about the different products. There's the types of AAV, there are different serotypes of this virus. There's different between the different products that are being developed, differences in dose required. And in some of the clinical trials, patient had to be, or sometimes did not have to be excluded if they had pre-existing anti-AAV antibody. But these are, I wouldn't say such big issues. One big issue, in my opinion, has been the question of efficacy. So in the clinical trials that led to the approval of the treatment, they were very much keenly looking at the ABR, the annual bleeding rate, the use of factor concentrate, whether factor levels were attained and maintained over time. But the main issue was the proportion of patients that after a number of years had to return to factor concentrate prophylaxis. In other words, their expression by the gene of the protein was not sufficient to protect them against spontaneous bleeding. And so in the case of hemophilia B, with the two products that are approved in Canada, over a 2 to 3 year follow-up, less than 10% of patients had to return to prophylaxis. In other words, these patients were free of any factor VIII infusions and had very, very few bleeds, and only 5 to 10% had to return. So a very fairly high success rate, whereas with hemophilia A, the success has been less. More than 20% had to return to prophylaxis. And this is in part due to, as you'll see, the expression of the gene that lowered over time. And another big issue had to do with the toxicity. And the main toxicity has been this hepatitis or liver transaminitis, which does occur in a number of patients and requires immunosuppressive drugs, immunosuppression doses of steroids at, let's say, 1 milligram per kilo for sometimes several weeks, which is something very that the hemophilia patients are not used to, and that has caused in that community quite a bit of concern and some of the usual side effects that are associated with prolonged use of the steroids. Because if it's not treated very aggressively, you lose the expression, you lose the gene, and your $3 or $4 million therapy, poof, is gone. So steroid use is a concern. And in the case of hemophilia B, less than 20% of cases have required this high-dose steroids for several weeks or months in the clinical trials, whereas you see in hemophilia A, more than 75% of patients have required steroid use. Another issue has to do with reimbursement. So this is a one in a lifetime infusion, and the advertised cost in the US is $3 million US per treatment. And in Canada, it is being circulated as perhaps being 4 million Canadian. So one big issue, even though 2 treatments have now been approved by Health Canada, no one knows if ever any of the provinces will agree to reimburse this treatment and under what condition and what circumstances. But it has clearly been shown to be effective in hemophilia B. Here you see that patients have, for over 2 years, maintained factor IX levels with a median and a mean that is above 25%. So although the patients are not cured, some of them have very good factor IX levels that are maintained over several weeks. Whereas with factor VIII, you have initially good levels, but they do come down, and more patients need to go back to prophylaxis. So this is what the slides shows as well. And this is, again, the rate of having to use corticosteroids. So with the hemophilia A construct, 80% of patients have ALT increases and need to be on treatments for a mean duration of 234 days. So it's not trivial, whereas in hemophilia B, the percentage of patients is much lower. So in summary, there's been very many truly innovative therapies introduced in hemophilia care in the last 5 years. The main one has really been emicizumab, which is in very wide use now and has really improved the care of hemophilia A patients quite a bit. This is based on harnessing progress in monoclonal antibody design and genetics. The patients have reduced bleeding rates and improving joint health and quality of life. And this is especially true for children and young adults who have not yet developed the debilitating arthropathy that we still see in some of our 30 and 40-year-old hemophilia patients who've been on prophylaxis for many years, but it's been a burdensome treatment and not always 100% effective. So these new treatments are less burdensome for patients and families, but they do generate more complex laboratory monitoring, and the adjunctive therapy in case of trauma, surgery, or intercurrent bleeding is a lot more complex with these issues of knowing where the patient's factor level are, and if in the case of these rebalancing treatment, treating the bleed without causing thrombosis. So these are some of the main references that I've used in the talk, and I'd be happy now to take any questions or comments.
Thank you so much, Dr. Saint-Louis. Wonderful lecture on this very complex topic. I'm happy to see that there's so much progress that's been made in this very difficult and complex disease. And I appreciate it as a sailor, all the sailing analogies. Thank you very much for that. I'll invite people to enter questions in the chat. Bettina, one of our colleagues from genetics, has a question for you. If you could please specify the minimum age for emicizumab treatment. You mentioned advantage for children. Is this available even at a very young age?
Yeah, so the current treatment guidelines actually recommend beginning very early to prevent bleeding. So it is being used as early as 6 months or 1 year of age. And if tomorrow a baby boy is born with severe hemophilia, he's likely to start treatment with imicizumab around 9 to 12 months of age, just as he starts to stand up and before he walks. This is generally when the first hemarthrosis occur. And he may not be exposed to factor VIII for many years. So this will cause a new sort of a happy problem in a way, because these families will not learn to self-infuse factor VIII. With imicizumab sub-Q, they may go several years without bleeding, but just like a mild hemophilia, when they bleed, they may present late and they don't know how to self-infuse. They may have to come to the emergency room to receive factor VIII treatment. So this causes new issues for the treatment teams, the hemophilia clinic, with these patients. But patients are eligible at all ages for imicizumab.
Thank you. I'm going to take a question from Mark Roger here, and then Molly, I'll ask you if you can unmute and tell us about your experience with your patient with the gene transfer. From Mark Roger, who I'm sure you know, is asking, will these effective novel therapies put hemophilia treatment centers out of business in 5 to 10 years or scale them back? What's your thought on that as Mark Roger is preparing the future needs of medicine?
No, I don't think they'll be out of business. I think that the intensity of care will be different. As I say, many patients will do very well and may require a lot less interactions with their nurse. But there's also other diseases such as factor VII deficiency, factor XI deficiencies, von Willebrand, severe von Willebrand disease, for which we don't have these innovative treatments. And even those who are on an imicizumab or have had gene therapy will require careful follow-up. So I don't see the end of the need for hemophilia treatment centers in the next 10 to 15 years. Who knows after that, but not in the near future.
Fantastic. Molly, do you want to unmute and tell us a little bit about your experience with the gene therapy for that patient?
Sure. Thank you for asking me. And Jean, thank you for such a wonderful talk. I think you really brought out all the really new, exciting, innovative treatments for these young boys and young men. And one more thing I would say to Dr. Rogers' comment is that I think over time, our hemophilia patient population is really aging. And so they're facing many of the same conditions that older adults face, and they will continue to need a lot of support through the Hemophilia Treatment Center. However, having said that, we were thrilled to be approached to be one of 2 Canadian centers for gene therapy in hemophilia B. It was or has been and still is a very challenging, intense clinical trial protocol. We had a very, very motivated young man, and I'm really happy to say I feel have completely changed his life. So I don't want to give up too much so that he can be de-identified, but he had such terrible hemophilia B, severe hemophilia B, that he couldn't even pick up his children without having bleeds in his elbows. And he was at a point where he'd had radioactive synovectomies. He'd had to start treating himself every second day with intravenous factor IX. Again, very motivated and joined our clinical trial. He did require steroids for a few weeks, mostly for his factor IX level. We're now maybe 9 or 10 months out, and he's doing extremely well with a not normal, but I would say mild factor IX deficiency at this point, and no bleeding events at all since he started on the clinical trial, and no hepatotoxicity. So he is super, super grateful to have had this experience, and we hope his future will continue to be bright.
Fantastic.
And it was a great trial to do.
Thank you so much for sharing that with us. Greatly appreciated. Ingrid Hings has a question. Can you provide lifetime estimate of cost of treatment with treatments currently approved in Quebec? What kind of costs are we looking at?
So typically, coagulation factor used to be priced at about $1 per unit. And if you were an adult with severe hemophilia, you would have to treat around 350,000 units per year. You would give a unit, 1,000 unit every day or 2,000 every other day. So you could say around $350,000 per year, from age 20 to age 60. But the price there's been competition. So currently the price of coagulation factor is more around 25 cents a unit. We don't know because, as you know, coagulation factors are considered blood products or blood products equivalent. So they're provided free to patients across Canada by the blood system, Quebec and CBS. They're not considered drugs, and they're purchased by these two blocks. They're purchased with tender contracts for all of Quebec and all of Canada at a bulk level. And so the prices are confidential, but we estimate that it's in the 20 to 25 cents per unit. So the prices come down probably to less than $100,000 per year to treat factor VIII or factor IX deficient patients with clotting factors. Imicizumab was approved because it was very efficient, although probably more expensive. Again, it is said to be about $400,000 per year in the US. In Canada, we suspect that they have been able to negotiate a lower price. So that's why they factor that if you give gene therapy and you cure the patient or you render them free of clotting factor treatment for 10 years, you could basically over 10 years have the same cost as if you were using imicizumab for 10 years. So this is how they came up with those prices in the millions of dollars.
Fantastic. We have time. We're going to take a last question. Then Chantal Séguin, I'd like you to just say a final comment there. Ivan Fantis is asking, is the difference in gene therapy for hemophilia A versus B to viral vector use or to recombinant protein?
Yeah, so factor VIII is much bigger gene than is factor IX. It's, I think, 3 or 4 times bigger in terms of number of kilobases. And there's a mutant factor IX, which is quite effective, called factor IX Padua, that has been used. So the level of transcription or transcription translation required is much less with factor IX than with factor VIII. I think the mechanics of it, the genetics of it are more complex with factor VIII, and that's why it has been more difficult to have a viable platform. They have to give larger vector doses. So this is where there's less enthusiasm for factor VIII gene therapy at the moment, although there is one platform approved by the FDA in the USA.
Fantastic. Chantal, we have 2 minutes left. Can you make closing comments for us, please?
Yes. Do I have the time to ask one little question before I do?
Yes.
The session? I would be interested to ask Dr. Saint-Louis, how do you see patients with hemophilia A, let's say, or B, with inhibitors, with the use of Hemlibra over time? I don't know if you have seen already the effects in your regular practice.
Yes.
And you were mentioning that we can use Hemlibra with or without inhibitors. And do you see also a difference in how they respond to the treatment, if they have or not inhibitors, and if over time you will not see these patients with inhibitors anymore?
Yeah, so this is a large chapter to open, but patients with factor VIII deficiency may develop IgG against factor VIII when you treat them, that they're called inhibitor. It's not an allergic reaction, but it's an inhibitory antibody that renders the treatment with factor VIII ineffective. And these patients were the most severe, and they're often in wheelchairs. They had severe arthropathy. And with Hemlibra, it really, really improved their quality of life. And these patients used to be in clinic once a month or every 2 months. Now we see them once a year, and they have been very much improved. Now, as patients are treated with Hemlibra from a very young age, but may be exposed much more infrequently to factor VIII, some of them will develop inhibitor along the way, but probably less because these young children will be less exposed to factor VIII.
I see. Okay, very good. Well, thank you so much, Dr. Saint-Louis, for this very, very interesting overview of hemophilia, and for also presenting the new revolutionary treatments in hemophilia. We can see that this is like a completely new landscape for this disease. And I think there will be a lot more to come. And we really, really did enjoy your presentation. And thank you so much for accepting the invitation today.
Welcome. Thank you.
Thank you, Dr. Saint-Louis. Thank you, Chantal. Thank you, everyone, for joining us today. A wonderful presentation, a great way to start the new year. I wish everyone a great day, and we'll see you next week. Thanks, everyone. Bye-bye.